I think we can get started here. Apologize if we hear any background noise. I'm home with a sick kiddo today, so hopefully that doesn't interrupt anything, but just wanted to give you a warning. So yeah, thank you all for being here. This is our Essential Substance Abuse Skills webinar series. I'm Kate Trams, and today Steve Steiny is presenting on basic counseling skills. This training series is brought to you by the National American Indian and Alaska Native Addiction Technology Transfer Center. We are part of the ATTC network, which also includes 10 regional centers, 5 international centers, a network coordinating office, and the National Hispanic and Latino ATTC. In the next couple of days, we will send out a follow-up email to everyone who attended, which will include a link to the recording, handouts of the slides, and a CEU request form. Our center is an ADAC certified educational provider, and we'd be happy to provide you with CEUs for a $15 fee. Immediately following today's webinar, okay, just a second, honey, just a second, I'll be right there. Sorry about that. Immediately following today's webinar, you will be redirected to our GIPR evaluation. This survey takes just a few minutes to complete and asks about your satisfaction with the event. This feedback is critical to our future work, and we value your opinion and would greatly appreciate your time in sharing your thoughts with us. You will be muted for the duration of this webinar, so please use the chat pod to share your questions and comments, and we will address questions at appropriate points during the presentation. Today's speaker is Steve Steiny. Steve is our program manager for the Addiction Technology Transfer Center, and he has been an alcohol and drug counselor since 1997. He's worked in behavioral health services and in the nonprofit sector for the last 23 years and has been in recovery for over 32 years and is committed to his life and profession to helping others in the recovery process. So I want to thank Steve today, and I'm going to pass things over to him.
Thank you, Kate. Everybody hear me okay? I know I got some confirmations early. It's nice to see so many in the room today. We're up to about 36 participants, so that's fantastic. I appreciate all of you being here and taking the time to join us today to have hopefully dialogue. Although I won't be able to see or hear you directly, I know we're going to try and reserve some time at the end for Kate and I to field some questions. If we do run out of time or I'm not able to get to your question, please feel free to email or call me here at the center, and I'm happy to take some time to respond to any questions you might have. We've got a lot to cover this afternoon, so just want to say good morning or afternoon to wherever you find yourself listening this morning. I am broadcasting to you live from the University of Iowa campus here at the College of Public Health. I am, as Kate said, I am the ATTC, American Indian Alaska Native National Center Program Manager here at our center in Iowa City. And I come from a long history of working directly in the addictions field, both as a direct provider as well as administrator and manager of a clinic here in town. And I am in recovery. I'm a person of long-term recovery, which to me means that I haven't used any alcohol or other drugs since September of 1987. So again, I'm really happy to have all of you here. We have a lot to cover. For some of you, this may be a really good review, and others, this may be some information that you're hearing or being exposed to or thinking about for the first time. And I know that audience is pretty broad. Not sure. It looks like okay, Celia, you can hear now, so that's good. So we have a lot to cover, and I know we're going to be going through some different areas connected to counselor development, counselor theory. We're going to talk about self-disclosure. We're going to talk about a lot of things connected to someone either in the field, behavioral health field or addictions field, or someone perhaps entering the field for the first time. Before we start though, I want to just take a couple of minutes. Let's try and get centered, and then we're going to start advancing through some of these slides. I'm hoping that I can find my notes section.
Yep.
Kate, are you still with me here? Looks like okay. Yep, here we go. Yep, got it. Got it, perfect. Okay, thank you, Kate. Before we get started, let's just take a couple of moments to center ourselves, and I just want to just say a short opening blessing here for today's webinar. Creator, stay with us today as we go through this webinar and exchange and share knowledge and information. Keep our hearts and minds open to learning from one another, and let's have a good session, good webinar today. May all the listeners have good weeks. Watch over us, keep us in your light and protection. Thank you. Okay, let's go. We're going to talk about some basic counseling skills. If you are having trouble hearing me, let me know, and I can try and turn that volume up a bit more. But I did turn it up quite a bit, so everyone should be able to hear me just fine. So, basic counseling skills. Really, this is kind of an overview of some of the things we're going to try and cover today. Some of these slides I'm going to move through pretty quickly. Others we may pause on a little bit. And as we're going through, if you want to jot down a question or two, I may try and answer them as we go, or we may hopefully have a few minutes at the end to field some questions. So here's kind of our objectives. We're going to look at counselor development. We're also going to look at Alan Ivey's microcounseling skills. And then we'll also look at just some general counseling theories. There's quite a bit we'll cover there. And again, we're going to kind of skim the surface on some of these. We could spend probably an entire webinar or two just talking about the theorists out there, some of the forefathers, and then also some of the more contemporary theorists. We'll talk about self-disclosure and keeping clear boundaries. I think that's a really important part as a clinician is developing their skills to also maintain clear boundaries and really use guidelines for self-disclosure. And then we'll close with some cultural considerations along with some ethnic issues related to culture and working with native populations. Obviously, I'm not native. I am here at the center and am under the guidance and mentorship of Sean Bear, our co-director. He is teaching me and showing me many things about native culture, and I'm also have been blessed and fortunate to do some traveling and connect with other tribes around the nation, and I have felt nothing but love and kindness from everyone that I've been in contact with. They've invited me into their homes, into their sweats, and into their some of their ceremonies and gatherings, and it's been really special for me. So I'm still learning and hope to learn from you today as well as we go. So there's our goals and objectives. Something I want you to keep in mind as we go through this today, and I hope this resonates with some of you listening out there that are either working in the field or perhaps know someone that is. But I want you to keep this in mind as we go. A person's substance use is not really the problem. Rather, I want us to see this as an underlying issue, which that patient or person really hasn't yet found a meaningful way to work through or find a solution to. So for me, a person's substance use is not the problem. It's causing problems. Don't get me wrong. It's causing them problems, but it really isn't the problem. The problem is underneath that, what's behind their use. I hope that makes sense to some of you, and if not, I'm certainly willing to have more discussion about that to get your perspective on understanding substance use disorders. Let's look at counselor development. I want to first start off by just looking at a couple of different ways of thinking uh, and really looking at global versus linear thinking. And these concepts, I'm sure some of you have already heard about, so we'll just kind of go through these. But global thinking really is the process where the answer is already within the statement or the argument. It assumes to be true what you're trying to say or demonstrate, and the conclusion is a single assumption. Um, there's a certain starting point, and the thought process tends to jump forward from side to side through the steps of a project in an effort to see the bigger picture and tackle those areas where there's most interest. Linear thinking is the process really more step by step, and this is sort of how I was sort of trained and raised myself to think in a more linear fashion, which sometimes isn't always the best way to go about things. But this linear process is really seeing, where there's a response to a step, and that leads to another step. It has a starting point and an ending point. A is B, B is C, rather than A could equal C. Significant difference between the circular or kind of global and linear thinking is global thinking, the conclusion is contained in a single creative assumption, whereas linear thinking is derived from multiple solutions or assumptions. I also want to just briefly touch on this notion of the different way people learn. And I think this is important from a counselor development standpoint, but also just in general, just some human condition considerations about how we learn things. There are really three different types, and they're broken down into these categories: visual, auditory, and kinesthetic. And I tend to borrow a little bit from each one of these when I think about my own learning style or learning process. But I would say I'm probably more over a visual learner than anything else. So just asking yourself, how do you learn and process information? Is it global or is it linear thinking? Asking yourself, I think if we were in a live group, we might try a couple of exercises to demonstrate this. But for purposes of the webinar, just asking yourself, how do you process information that's given to you? And who in your life do you believe processes information on the other end of the scale from you? If you can think of somebody that maybe processes things differently than you, a partner or a colleague or a family member or someone that you know. And then how do you adjust your communication when speaking with a person who processes differently than you do? And then how do you feel your best sort of learning medium is? What's the best format for yourself? Those are some things to consider. So let's just do a quick polling question here. I'm just going to ask you, what type of learning process do you most identify with? So let's see if we can open that up.
Sorry about that.
Kate, I assume we have a poll available for folks
I forgot to add that in here, but let me see if I can pull that up here.
Well, and maybe just folks can just kind of give themselves. Oh wait, here we go. Here we might have a polling question coming up here. Kate's working her magic, maybe. Oh yeah, we have. Looks like a few people maybe are trying to chime in, but it looks like there's a lot of visual learners here in the audience, just based on some of the chat box responses. So, and that doesn't surprise me. But I think we can also relate to some of the other, the auditory and kinesthetic processes can also be popular. But it looks like we've got quite a few of you that are identifying with a visual learning process. So thanks, Kate, for popping that up real quick for everyone. So I want to, so let's build on that a little bit, and let's look at sort of this integrated developmental model. And I really want you to think of this as a progressive theory of your own professional development. If that makes sense, as your think of it as your own development in the field. Kate, I don't know if we can take that polling window down. Looks like, yeah, majority of you identified as visual learners. So, but think of an integrated development model as really, thank you, Kate. I just can't see my video feed now.
Great. I took down the webcam because it wasn't. It didn't show your. Were you trying to run your webcam?
This as.
Okay. I don't think. So yeah, here I'll pull that back up and then we can share that. I just
maybe I wasn't.
Let's see. I think.
Can any of you see me out there? Anybody able to see my there? There I am again.
One second, I'm gonna just move things around here, but I'll pull that up, Steve. And then I think, do you still see the start sharing?
There we go.
Okay, one second.
Yep, I think maybe I just didn't hit the start sharing. Okay. Yeah, Nora says she can't see me. Robin's. Okay, well, anyway, think of the integrated development model as really a progressive theory of your own professional development as clinicians working in the field, behavioral health field or related field. Let's look at the integrated model. So it's really clinicians, as clinicians develop in a step-by-step approach. That's this idea that Stoltenberg, McNeil, and Delworth had. The clinicians are seen to move through 3 levels of development in a relatively orderly fashion relevant to professional activities. The model allows for brief regressions when clinicians or counselors are faced with new or tasks that are unclear. And this makes sense to me. In my many years of training and assisting new clinicians entering the field, it was very important to provide step-by-step orientation and clinical training, starting with many of the current assessment and evaluation processes used to determine the patient's social and diagnostic history. I think this sort of starting point is really thinking of it as building a foundation for a house. You need to have a solid foundation if you expect the house to stand and function for many years. So that's sort of the way that I think of this integrated model. So building on this idea, people are continually growing, and growth is not linear, but it can be in spurts or sporadic. Growth can be affected by changes such as caseload, treatment setting, supervisory relationships, and the populations that they're serving. So think of it this way. Excuse me. Think of it as these 3 levels that I mentioned earlier: beginning, intermediate, and advanced. And then think of sort of the overriding structures of your own self and others' awareness. So being aware of self and others, your motivation, and then your ability to work autonomously and at a level of mastery. So there are sort of, it's broken down into 8 different growth areas. We're not going to have time to spend time going over each one of these, but we'll touch on them. But those are some of the 8 growth areas. You can see they really start off. There's your intervention and assessment, your interpersonal assessment, patient conceptualization, and so on, and finishing with treatment planning and goals, and then some ethical considerations as well as you develop your own working understanding of ethics and how it relates to your field. So if we look at this idea of the levels of counselor development, we see these developments we can break them down into level 1, 2, and 3, if that is a better way to look at it for you, beginning, intermediate, and advanced. In this first level, or level 1, the clinicians are full of hope and trust. Level 2, they may start to have some some conflict about this notion. They're working to be independent and establish themselves, and they may have some sort of rigid notions or ideas about what their job should be or how they should go about connecting with patients. And there'll be some level of disruption as they come into their own and start to understand how they want to connect with patients and how they want to assign meaning and purpose to the work that they're doing. Level 3, I would describe this as the beginning of the clinician's true work experience. As the clinician develops beyond this stage of growth and understanding, their work will take on more and more meaning professionally, personally, and I would say spiritually as well. Think of this, though, as the kind of the calm after the storm. You've worked through some of the initial ambivalence and coming into your own to understand your own style, your own theoretical base, and now you're starting to really find your stride in your work. I want to shift quickly and look at some microcounseling skills. I'm sure any of you that have done any formal training or have worked with a supervisor or perhaps mentored others are familiar with this concept of microcounseling skills. These skills can be learned, but I would safely venture to say that those of you listening today are likely innately gifted with many of these skills already. And I would say that otherwise you probably wouldn't be involved in the helping professions. I can remember taking microcounseling skills courses in graduate school where we were required to videotape. We were still using videotape back in those days, but we were required to videotape a lot of our mock sessions, and then we would have our peers and our graduate instructors go back and critique our use of microcounseling skills. So let's talk a little bit about microcounseling. Alan Ivy is sort of the forefather of this idea, and he really was able to articulate and identify this microcounseling skills approach. I'm sure some of you are familiar with his work. He's got a lot of publications and reference materials out there if you're interested on microcounseling skills. But really, microcounseling is really taking a really close look at the skills and elements of the counseling relationship. Regardless of the aims and methods of counseling, it's really about trying to understand its elements on a real micro level to help the clinician ultimately improve their effectiveness. And I would say, too, that there are many of these that you will see, some of these skills will present themselves in other theoretical approaches. But active attending and attending behavior, so really the counselor's interest in the patient's demonstrated by nonverbals, so eye contact, body posture, and accurate verbal following, and then attending behavior just encourages the patient to share and also encourages active listening on the part of the clinician. I know we're familiar with open and closed questions. things like, can you tell me more about that? Open questions, I firmly believe are a wonderful strategy to elicit discussion and sharing. Close-ended questions have their place as well. And I just would say, when do you think it would be better or suggested to use closed-ended questions? There's a time and a place for that. But you want to make sure you don't get into kind of a yes and no exchange. I would say that probably using closed-ended questions during an evaluation process sometimes can be a benefit so that you aren't getting bogged down in a lot of detail when you're trying to get a snapshot or some information during an assessment or an evaluation process. Reflective listening. This, I think, was really important in my own early training and development as a clinician. I often wanted to problem solve or fix things, and just have to be mindful of this trap. It's easy to want to try and get in there and solve without listening fully to what's going on. Your therapeutic relation relies on understanding why your patient, in the case of substance use disorders, why they started using substances in the first place. It's not to make them quit or to change, their mind or change them because you want to feel effective. I hope this makes sense. So listening reflectively is a very important part. It allows for you to identify mixed messages, contradictions, conflicts, and incongruities. But the task is not to problem solve, but to understand where the patient is coming from. Later on, when we talk about motivational interviewing, some of these concepts will reappear and allow you to create some dissonance with the patients you're working with and help them to solve their own problems through their own understanding and deduction. Encouraging, paraphrasing, and summarizing. Again, this is part of that reflective listening. This really, I think this is important. It really lets the patient know that you're following them and understanding them. Reflecting feelings. So reflecting feelings, the patient's feelings, either stated or implied, as expressed by the clinician, and then the feelings of the patient can be verbal or nonverbal. They really can be expressed in either one of those ways. Reflective meaning, finding the deeply held thoughts and feelings underlying life experience. And I think this is at the root of creating that therapeutic relationship and collaborating with the patient. Paraphrase, I like this idea that paraphrasing is to thoughts as reflection is to feeling. So, and it helps to break down some of the behaviors into manageable parts. This process also allows for you to confirm and affirm where the patient is at in their recovery process. I'm a firm believer of that. Empathy, I think, too, is an important factor in this ability to understand and be with your patient and connect with them. Empathy is a great bridge builder in the shared human condition. However, I would caution you not to lose sight of your role and purpose as the clinician or therapist. It's very easy to be pulled in too deeply into empathizing and forfeit your objectivity as a clinician. I'm sure we could have a discussion about that too if we were all sitting face to face. But understanding what the patient is experiencing and putting oneself in the patient's place. The functions really are to build that connection with the patient and enables the clinician to better understand the patient's behavior, things connected to their behavior. And common problems with conveying empathy, language and cultural differences sometimes can be a barrier to truly empathizing with a patient. Polling question. Let's see. This is another polling question. Kate, I don't know if we have to set this one up again, but this is just sort of a general question for you to kind of think about. Which of these micro-counseling skills is most challenging for you? And to think about that, I don't know, maybe we don't have the ability to poll that one, but oh, maybe it is there, yeah. Okay, we've got, looks like we've got a vote in. Oh, here comes some votes, so yeah, take a couple of minutes. So which of these micro-counseling skills that we went over briefly, I know it was quick, but which of these, based on your own knowledge about your own development as a clinician, do you find most challenging? Looks like we're tallying some votes here on the poll. So we've got a few people coming in. Yeah, it looks like open versus closed questions, and perhaps some reflective listening. Folks find challenging. So again, that's just some food for thought. A couple more votes may be coming in, but we'll move on. I want to look at again. We're going to take a quick look at this is a skimming sort of overview due to just for time considerations. We are going to look at some counseling theories, and some of these are going to be familiar to you in the audience. Those of you that have done some clinical work are going to be familiar with some of these, but this really is more to give an overview. And again, we could probably spend an entire webinar to reviewing some of these theoretical approaches to working with patients in a clinical setting. The first one I want to open up with is the psychoanalytic perspective, and this we'll look at a couple of theorists that are connected to this, but this consists largely of using methods to bring out this idea of the unconscious, working through the past, transference relationships, focusing on childhood experiences, and it's said that this really does require some specific training and practice to really master, so that you can use these types of psychoanalytic approaches effectively. Of course, we have to mention Sigmund Freud. In all of his brilliance and faults, he is really the forefather of the psychoanalytical perspective. Freud really looked at the struggle between life and death instincts, the dynamics of the unconscious and how it affected our behavior, the role of anxiety as a motivator, and then this idea of the id, the ego, and the superego, and dividing them into these sections, and then development of the personality at different periods in a person's life. Sort of on the coattails of this was Erik Erikson. He broadened this developmental perspective for the early childhood experiences, and really looked at establishing a balance between ourselves and the world around us, this sort of biopsychosocial world around us. And then looking at crisis as sort of synonymous with a turning point, the ego, developing strength as ways to deal with some of the challenges or tasks, and then also looking at personality in stages. Carl Jung also really adopted many of the early approaches in some of the psychoanalytical theories, psychological aspect of personality development during midlife, views humans in a real positive manner, looks at them through an individualistic view, and really attaching this spiritual component, this idea of a soul and a spirit being connected to one's attaching meaning to life. Consistent development growth and moving towards a balanced and complete level of development. There's a great book out there by James Hollis, if anyone's interested, for those of you in that 40 to 60 year age range. It's It's by James Hollis. It's called Finding Meaning in the Second Half of Life. And he references many of Jung's teachings in this book. It's a pretty quick read, but I found it quite meaningful from my own perspective. Really, the overview of the psychoanalytical approach. It had some limitations. Obviously, the lack of ego strength needed for change, this biological sort of predisposition. It placed a great level of responsibility on parenting and the role that the family or parents had on a person's issues. And then just the cost. It's just long. This is long term. You might see a patient for years with no real end in sight. And it was difficult to measure outcomes, how the person was improving or not improving. Contributions, obviously, it added to the conceptual framework for looking at behavior connected to thought and connected to a person's cognitions. Past experiences may pertain to current life. It brought that idea into play. Value and role of transference, and overuse of ego can keep patients from functioning effectively. And then the role of early childhood development. Those were all contributions made by psychoanalytic perspective. The Adlerian approach really, Alfred Adler really looked at the goal of helping patients to identify and change their sort of belief systems about their life and participate in the world in a different way. He thought people needed to understand and confront basic mistakes. He knew that the family was an important component, and really wanted to see this notion of collaboration and connection between the clinician and the patient. The Adlerian perspective, had its limitations, as most theories do. It was difficult to validate a lot of the hypotheses through empirical support and detailed exploration of early childhood memories and dynamics within the family. Contributions really were identified as working out an action plan to make life changes. Really saw people as social, goal-driven decision makers, and it also brought this notion that there was an understanding about the unique world of an individual, and it was also sensitive to culture and gender issues. So those were contributions that this Adlerian approach offered to the field early on. The existential perspective, I think, is also an important one to review. Viktor Frankl and Rollo May, sort of at the forefront of this approach. Just really philosophical approach that influences the clinician-patient dyad or therapeutic process. Not the victim of circumstances, because to a large extent we choose to be that way. We choose to be the victim, is what this sort of existential approach suggested. Really asked for self-awareness in the therapeutic process, process of searching for value, meaning, and purpose in life, based really on the individual worldview, and that people are faced with anxiety of choosing to create an identity in the world that lacks meaning. And that's a very interesting concept that this existential approach afforded patients to consider. There were limitations, obviously, and some contributions. The existential perspective itself, it lacked a systematic statement of principles and practices of the psychotherapy. It lacked rigorous or standardized methods. Its concepts were often abstract or ambiguous and difficult to sometimes articulate, and highly focused on philosophical assumptions of the notion of self-determination. The contributions is that it was very patient-centered. The emphasis on this idea of the therapeutic relationship having a strong quality to it, and individual freedoms were really connected to retooling one's life by being aware and being cognizant of what was happening. So that's, again, these are just quick overviews. The person-centered approach. Carl Rogers, I think, was someone that I was attracted to his approach early on when I first started to look at theories. Carl Rogers is this branch of existentialism, but he really believed that there was the capability of self-directed growth, and that a person could resolve problems without the therapist being directly sort of telling them how to do this. Really allowed for some efficacy and some idea that the patient had control over making some changes. The role of the therapist was to just be there rather than to do something or fix something. It focuses on the person. Each of us has within us, by nature, a potential that we can actualize through what we can find, where we can find, and which we can find meaning through that process. And just this idea of striving for self-actualization was an inherent part of this person-centered theoretical approach for Carl Rogers. Limitations included this lack of sort of challenging or being able to confront the patient in a gentle way, and just being supportive sort of unconditionally. Limited techniques in attending and reflecting. The therapist training, there was more emphasis on attitudes of the counselor. And then individuals may not have within them this growth potential or ability to trust their own inner directions. A lot of emphasis was placed on that, and there were some patients that were not capable of that. And then contributions, just stated concepts as testable hypotheses, and was submitted to research. And then this idea or notion of a non-confrontational or non-sort of directive counseling approach. I really want to stop for a moment here and talk a little bit about motivational interviewing. I know this has been sort of in the milieu of many programs in the last 20 years. So I know many of you listening now are familiar with the spirit of MI, at least, and what that involves. I always liked Rogers' approach and to counseling, and so when I was exposed to MI, when my clinic adapted this approach early on, I thought, boy, this is something that really seems like a natural fit in working with substance abuse disorder patients, whether they were in a early, low level of readiness to change, or very much in an acute state of their substance use and really ready to consider making long-term changes. But MI really is using, in a nutshell, it's using specific language and specific strategies to empower the patient to make changes in their lifestyle choices. It is patient-centered, and it really allows for, it's non-directive, much as Carl Rogers' approach, and it allows for the patient to really come up with their own reasons for making changes, and using specific language and specific strategies. It takes the emphasis off of the clinician to solve the problems, and really allows the patient to feel empowered to do so. But MI is most certainly defined not by technique, but by its spirit as a facilitative style for this interpersonal relationship. So MI, again, it's a form of it's a form of directive. It's patient-centered, and it really encourages patients to explore these discrepancies or incongruencies between what they hope to attain in their lives and how they're actually living and behaving. And again, it's using that specific language um, and specific approach to empower patients towards positive lifestyle changes. I assume many of you are familiar with MI. And there, I know that there's evidence too that the developers of MI, Miller and Rolnick, there's evidence that Miller was spending time with Native communities in the Southwest when he was formulating some of his early motivational interviewing theoretical guidelines. So I always found that interesting too. Um, but MI is considered as an evidence-based practice for the treatment of substance use disorders by SAMHSA and has been extensively applied in medical care as well as health and substance abuse treatment. Limitations, obviously, it does not, address this urgency to change. There's questions about, leadership when connected to motivational interviewing, and there's no real methodology for highly resistive or patients who would be deemed at a pre-contemplative stage or low readiness to change. Contributions include triggers to change. Triggers change in high-risk lifestyle behaviors and increases the willingness to get help and fight through substance use disorder issues, increases participation rates during any treatment program, and allows for individuals to find encouragement during treatment and to establish some efficacy and self-actualized goals. I would encourage, any of you out there who are not familiar with this, or if your agency is not utilizing the motivational interviewing approach, to talk to your administration or your leadership at your clinic and see if it's something they'd be willing to take a look at. I think it's important. It's a wonderful approach. It really is allowing the patient to explore possible solutions without you providing them to them. So, Gestalt therapy. This is a forefather. Fritz Perls really looked at this idea. It's sort of a combination of an existential approach with this phenomenological approach. I'm so glad I was able to say that word. I always get stuck on it. But it's based on this idea that people must find their own way in life and accept their responsibility if they want to mature and grow up. I'm still trying to figure out what I want to be when I grow up. So Fritz probably would have been frustrated with me as a patient. So in this notion, though, therapists do not aim to change their patients, but rather assist in experiencing all the feelings, and they avoid interpretations and focus on patients' behaviors. It's really technique based. If you get a chance to, there's some wonderful old footage on YouTube of Fritz doing this therapy, or demonstrating this therapy with graduate students in the early 70s. And if you can see through all the cigarette smoke, it's actually kind of fun to watch. But it's really based on patient self-awareness. The limitations, obviously, the de-emphasis on this idea of identifying thoughts or cognitions, not used, doesn't match well with patients with an abuse history or a trauma history, and also it's dangerous as the results of the therapist's power to manipulate the patient through these very sort of directive techniques. So if you watch some of the old footage, it's really pretty clear that Fritz was in charge of that entire session. Contributions, it is rooted in action, the patient taking action. It pays attention to verbal and nonverbal cues. It confronts people gently and compassionately. Its perspective on growth and enhancement were acknowledged, and it's rooted in the here and now. So, the Gestalt approach was one of the first sort of ideas of focusing on the now, not the past or the future, but what's happening right now. Interesting approach, though. William Glasser, this reality perspective or control perspective, it rejects the medical model. Patients, William Glasser believed that patients live in an external, internal world. Clinicians function as the teacher or a model and focus on personal responsibility, total behavior, looking at only at behaviors. Patients have psychological needs for belonging, power, freedom, and fun. Very interesting perspective. The limitations were the de-emphasis on the counseling process, does not take into account the unconscious, and vulnerable to the counselor who assumes the role as expert in deciding what to do for others. Contributions were identified as short-term focus dealing with conscious behavior. Contract approach, sort of punishment and blaming, is a basic reality, and this psychosis can be related to unfulfilled needs. Looking at the behavioral perspective, we'll look at a couple theorists here. Arnold Lazarus, he looked at the interplay between individual and environment. He looked at the emphasis on specific goals at the onset of therapy, basic scientific method, looked at therapists using summarization, reflection, clarification, and open-ended questioning. He also expected patients to engage in specific actions to deal with their problems. And the therapy is a collaborative partnership. So that's something we would also see in some other patient-centered approaches. And also looked at patients in three major areas of development. The limitations, change in behaviors, not change in feelings. So I'm going to change the way I'm acting, but really still feel the same. Ignores importance of relational factors, does not improve insight, treats symptoms rather than the causes, and involves control and manipulation by the therapist. So clearly there are some limitations. But from a behavioral perspective, the contributions were identified as cognitive factors and subjective reactions of people to the environment, systematic behavioral, some systematic behavioral techniques, and some ethical accountability were also identified as contributing factors in this approach. Cognitive behavioral perspective. Again, we know that the CBT therapies are very much identified now and utilized heavily. These are just some of the forefathers of the cognitive behavioral approach, really looking at rational motive behavioral therapy. This was utilized heavily in the 80s and 90s. I think it's still being used today. This idea that emotions stem mainly from beliefs, evaluations, interpretations, and reactions to life situations, whether they were right or wrong, was not for the clinician to decide, but rather to identify. Active directed techniques, and several other factors. Challenging the belief systems, so some of the irrational belief systems that a patient might bring into the therapeutic diet. The therapeutic relationship, collaborative, the patient and the clinician working together, teacher and role model. Psychological distress is largely a function of disturbances in cognitive processes. So I think about cognitive behavioral therapy is one of the few forms of psychotherapy that has been scientifically tested and found to be effective in hundreds of clinical trials for many different disorders. It's important. I think cognitive therapy is usually focused on the present. It's time limited, and it's oriented towards problem solving. Patients learn specific skills that they can use for the rest of their lives. And these skills can involve identifying distorted thinking, adjusting or modifying their belief systems, and then relating to others in different ways and changing their behaviors. I think about this as connecting cognitions to behaviors and really affecting change as a result. But the patient has to be active in this theory, this theoretical approach. Limitations included: it does not encourage patients to address unfinished business. Personal warmth is not an essential part of this therapy. Potential for transference is there. There's less concern with unconscious factors and ego defenses, and confrontational therapy, has advantages and disadvantages. If I'm telling you the way you see something is irrational, that could potentially be or re-traumatize the patient or cause some distress, depending on how I go about presenting that. Contributions, just the self-responsibility in maintaining self-destructive ideas and attitudes, so trying to undermine some of the self-destructive belief systems. Emphasis on putting newly acquired insights into action teaches the patient to carry on their therapy in practice, and a comprehensive and eclectic therapeutic practice. So those were some of the contributions. Family systems perspective. These are just a few of the clinicians historically that are seen sort of as the spearhead to this family systems perspective or approach. And I know those of you working with families or working with those affected, significant others, or individuals affected by substance use disorders or mental health issues, family systems perspective can be a very important component to how you connect with and work with patients, identified patients, and their family members. But this family systems perspective really looked at the cause of the problem as understood by viewing the role of the family and unresolved emotional fusion to one's family, emotionally detached therapist, teacher, model, and coach, and the here and now interactions between family members, and the techniques such as family mapping, enactments, and I think probably is it the ideogram or trying to think of the other one where you do the family sort of tree, may also be part of that, some of those techniques. Family systems perspective had the limitations. Patient may be lost in the system and the language. It may be stuck in the dysfunction, and there may be some enmeshment and some disengagement on parts of family members if you're trying to treat the family as a whole. More research is needed, and I think that's continuing to happen. And as this family systems perspective evolves, contributions really included that the family has this notion of being empowered, that it's neither the individual nor the family that are blamed for a particular problem, and understanding that the individual exists within a system. So this idea, this integrative perspective, creating an integrative stance is truly challenging. It doesn't, if we're talking about your development as a clinician, I found myself doing this, borrowing bits and pieces from different theories to try and couple them together to make something work for me. But think of this integrative perspective as you evolving your own theoretical approach, and it may be rooted or based in one or two theories that you identify with based on your own personal experiences and how you connect with the patients that you're working with. But this is a long-term venture, so your agency can really assist you as well. I know in my own clinical experience, when we moved away from the traditional sort of disease model approach and into some evidence-based practices, including motivational interviewing and stages of change model, I was able to really conjoin those two models and really apply them to our patient population with great effectiveness. And it was a great match for the patients that we were working with. So that I just want you to keep that in mind. So which of these theories are you most drawn to? This is another polling question. There's no right or wrong on these. This is more just for you to have some food for thought and to think about which one of these approaches have you currently adopted or are practicing, or are there those of you that are still in the early stages of developing your own theoretical approaches or techniques based on one of these theories that we've talked about. So it looks like we've got early voting is really leaning towards the motivational interviewing. There is some folks chiming in with a psychoanalytical approach, which is not surprising. There are some other theories too that I wasn't able to include just due to lack of time, but wanted to at least acknowledge some of the traditional 12-step approaches and the disease model theory as well have their own set of limitations and contributions. But it looks like a lot of you are identifying motivational interviewing as an approach that you're drawn to. So assessing readiness to change, I think this is, I would just ask the question, why do people change? Why do you think people change? I've heard some people say, why do you think people don't change? But I would just say, well, in general, why do you think people change? My experience, both professionally and personally, has been that people change when they are or what they're doing and the benefits that they are receiving through their actions and decisions are being outweighed by the consequences. So if I'm making this choice and gaining this, the consequences begin to outweigh the benefits, and then I become more ready to consider change. Does this make sense? I am more ready to make change regarding my job when the benefits and rewards are finally outnumbered by the losses and the penalties. There's a number of different, analogies we can use or examples that we can use, but my readiness to change might be different than yours, even though our situations may be very similar. Change is challenging for me personally. I try and avoid it when I can. That's just how I'm wired. I don't like change. Others thrive on it. I have a friend who just says he's a change agent. He just really enjoys changing and changing it up, and I always admire that in people. Using stages of change within the context of substance use disorders is something that this Prochaska and De Clemente model, the stages of change that were originally developed in the 80s to address smoking cessation, have now been applied to a number of different contexts, including substance use disorders. And it really is this notion or idea that people are in different levels of readiness to change. And sort of in a nutshell, if I, as a clinician, and the patient can explore where their readiness to change lies, it allows for myself and the patient to adjust the approach, the goals, some of the techniques and strategies, the length and duration, the type of connection I have with that patient will be directly connected to their level of readiness to change. I think it's extremely important to keep this in mind. An example would be if I have a patient who is in a pre-contemplative stage of change, and I'm sure many of you understand that concept. So in the old days, we would say that person's in denial. We don't even use that term much anymore. If a person's in a pre-contemplative stage of change, my goal or my sort of default goal of them remaining completely alcohol and drug free may not be a realistic goal for them. we may need to adjust that goal, and based on their level of readiness to change, have them reduce or modify their substance use or their alcohol use, as opposed to um, having a goal of complete abstinence. I hope that makes sense. We could spend a lot of time discussing the stages of change, but again, due to time constraints, I want to move on. If you're interested in this and want more information, I have a bunch. And talk to your agency too. They may be already promoting this. If your agency is promoting this, wonderful. I think it allows for you to treat a broad range of patients, not just the acute chronic patients, but folks that are in the early stages of their use, or perhaps in a midpoint. But adjusting and identifying their level of readiness to change will directly impact the approach that you take with them. Let's talk a little bit about self-disclosure and keeping clear boundaries. I can't again stress enough how important this is. But you know, I'm always I would always ask myself, is what I am disclosing to the patient, um, is it a benefit to them? Self-disclosure and keeping clear boundaries. Self-disclosure is sharing personal, emotional, or experiential information. Self-disclosure on the part of the clinician requires careful tact and consideration. Consider alternatives, and above all else, we want to do no harm. Um, Self-disclosure can be a slippery slope, and I'm saying that to all of you, those of you that have had clinical experiences, especially if you're working out in rural areas or doing home visits. I can't tell you how important it is to keep clear boundaries and maintain and limit your self-disclosure. The clinic that I worked with, for better or worse, had a policy where we, as clinicians, were not allowed to share our recovery status with the patients, and that had both pros and cons to it. But you had to be very careful about how you disclosed and what you disclosed. But self-disclosure and keeping clear boundaries. So self-disclosure barriers, slow down or even stop sharing. Stop the sharing process altogether. Patient may may lose confidence in the counselor, and the patient may move away from their own issues. So it's something to keep in mind. How often did informal discussions occur? There was a study done a while back, about a decade ago, where they looked at motivational interviewing and motivational enhancement sessions, and looked at the amount of informal or small talk that was going on during those sessions. And this was just some of the data from that. And then moving forward, this idea of self-disclosure guidelines, just some things to keep in mind. Wait, be brief in using I statements. So kind of asking yourself, why am I sharing this? Being brief, keeping it to the point, and maybe a little more general, and then using I statements to make sure that you're not taking interest or focus away from the patient. Consider your own patient's values and consider the impact it may have. If I share something that's going on with me that may be unresolved, it may really impact what the patient is willing to or able to share based on that. Self-disclosure pros, I mean, there are many. It can quickly build rapport and trust. It can provide validation. There were many times when patients would say, well, Steve, are you in recovery, or have you ever drank or used drugs? And it was really difficult at first for me not to say, I understand, I've been there. Be able to answer that in an indirect way, or a respectful way that still gives the patient acknowledgement that that's important to them to connect with others that understand where they're coming from. But it can be difficult. But it can reduce the power differential and flatten that relationship. It helps the patient feel as though they're not alone. And there are other ways you can do this without self-disclosing that we don't have time to talk about. But just saying, just making a normalizing statement, such as there are a lot of people that struggle with this very thing that you're going through now. Or I've worked with many patients, or I've known many patients that have struggled with this very same thing. And there is a solution, and we'll talk about that. And then providing role models for appropriate social interaction. So one of the things that would come up in my own experience was I would go to an AA meeting, and sometimes I would run into patients there. And that was, at first, I was very resistant and sort of ashamed of that, thinking, oh, they can't see me like this. However, if they saw me at a meeting, that might be a great way for me to role model for them, so that when we talk about recovery, they know that that's one pathway that you can utilize to sustain or maintain your early recovery. And then the cons, obviously, there's some boundary issues that can come up. It can create role confusion. It can move focus away from the patient. And there's several others that I've referenced already. But it can blur the lines and cause some confusion. So the bottom line is use tact and discretion, and consult with your supervisor. Look at your agency's policies and see what their policies are about self-disclosure. Some agencies, clinics are very lax about that and don't have a definitive policy, and others do. Here's a polling question. How helpful do you think informal conversations are in the therapeutic session? Little helpful, moderately helpful, or very helpful? Give people a couple of chances here to chime in. So how helpful do you think informal conversations are in that therapeutic session? And remember, they did a study on this a while back. I referenced it a few slides ago, where they followed up on this and measured how often informal conversations took place, and then matched that up with outcomes. So let's see what we have here. So it looks like many of you are chiming in. We do have many of you saying very helpful. Doesn't look like looks like there's some discrepancy between the polling choices and the polling question up there. But what I can say is that the data and research on the study that was done showed that informal conversations in the therapeutic session have very little impact on the outcome, which I thought was interesting. I thought it would have been, as many of you thought it, that it would have been very helpful. And there may be some cultural components to that as well. I oftentimes, especially if it was a patient that I've been working with a while, we would often have history and share stories or experiences. So there may be some exceptions to that, but the idea is that informal conversations or small talk in the therapeutic session don't impact outcomes, so they are deemed as being a little helpful. In closing, I just want to take a look at some cultural and ethnic issues, things to consider. Again, I am not native, but I still want to review some of these components, and certainly would be open to suggestions or feedback from any of my Native brothers and sisters listening in today. So let's look at culture. It's a key element which enhances opportunity for change. I like that idea. What is culture? Well, it's everything that people have or think or do as members of a community or society. It can be material things. It can be ideas, values, attitudes, or behaviors. It can be dynamic. It can be shared and learned. It can be sort of a guideline that shapes behaviors and consciousness within a human community or society. One's culture is shaped by history. It's shaped by religion, ethnicity, geography, group membership, or the sort of a subculture within a culture. Part of becoming a clinician and developing as a clinician, really asks one to understand diverse cultures and incorporate the relevant needs of cultural diverse groups, as well as people with disabilities, into their clinical practice. It's culture can be so broad and so extensive that many things need to be considered when looking at cultural adaptation or adjusting one's approach based on a patient's culture, cultural beliefs, or ideology. This addressing model is something that I'm not familiar with, and I wasn't familiar with until I had been exposed to this PowerPoint and this notion. But this addressing model kind of gives us a framework for understanding the effect of diverse cultural influences on the clinician and the clinician and the patient's worldview. Why is this important? Well, the knowledge of the patient's salient identities gives us clues to how the patient sees the world, so their worldview, what they value, what's important to them, how they may behave in certain situations, and how they're treated by others. The more we know, the closer our hypothesis or our speculations will be to the patient's realities. The greater our credibility and efficiency and accuracy stand to be increased or improved. But there's that addressing model. Again, I think we could spend some time pushing this around too. I think this is very intriguing, but just this each letter being connected to all of these different areas as we look at one's sort of cultural identity. I think this is extremely important and really helps me understand the broad context of what it means to really understand your patient's worldview and how they see things. And then just to address privilege versus oppression, we all have these sort of addressing areas of privilege and oppression. We tend to be more aware of the oppression. Privilege areas present a greater challenge for the clinician, and I can say, having grown up in the Midwest as a white adult or white male, many of the things, the privileges that I may have been afforded were things that I never really thought of as privileges. So it's really a matter of perspective and being aware of that. We need to consciously work to increase our awareness about our areas of privilege. Increasing our awareness. Investigate your own cultural heritage. Pay attention to the influences of privilege on your understanding of these cultural issues and the work that you do with your patients. Educate ourselves through diverse sources of information, and then develop these sustained diverse relationships. I really like the idea of, learn from diverse groups, not simply learn about them. So part of my own cultural awareness and my being culturally informed is to really travel the country and connect with other tribes and be part of some of their experiencing some of their culture. And it's given me a much deeper understanding. Still have a long way to go, but it gives me a much deeper understanding and appreciation for many of the native cultures and communities that I've been able to be invited into. I just wanted to give a shout out to Dwayne Mackey. He was here before I arrived, many years before. Was a big part of our center here and really was responsible for many of the initiatives and curriculum that we offer to Native communities around the country. So I wanted to at least acknowledge Dr. Mackey. And then just these statistics probably need an update. I did update I just got the list of the 574 federally recognized American Indian tribes and Alaska Native groups in the U.S. I think it went from 565 to 574, and some of the census data is probably um, needs to be updated since 2010. I think those numbers have increased across the board. And then just again some overview of some of the nations and tribes and the bands. Santee and Teton and Yankton tribes are bands in the Great Plains. And then this map always is striking to me and continues to be something that I don't take lightly as a non-native. Just seeing the absolute decimation of native lands in this visual demonstration. And then just in closing, we have a few slides to go, and then I want to make sure we have some time to do some questions. Yes, you're right, Drexler. It relates to the Trail of Tears. Thank you. Thank you. Just as far as Native Americans, some things to keep in mind. Just cultural values include harmony with the environment. Individuals are part of a larger system. Respect for elders. This idea that the children are the future. Importance of helping others, and prayer and traditions. Interventions with Native Americans. Development of interventions must consider the following: specific socio-political history, really thinking about historical trauma and some of the components of that. I'm learning and continuing to learn about the genocide and the atrocities that occurred over time. And really important to understand the socio-political history and to know how important that is and how important it is to continue to acknowledge and work on the healing component of that. Continuing transfer of unresolved trauma and grief across generations, socioeconomic conditions, and the current and past experiences of racism and oppression. Tips for the clinician: be aware of the many ways of perceiving and understanding and approaching health, wellness, and healing. Be careful not to misinterpret, stereotype, or otherwise mishandle encounters. Be aware that ethnicity is used to stereotype diversity and can lead to distrust. Assess the degree of acculturation in the target group, which Sean Bear, our co-director, has talked to me a lot about that, and as I've talked with others on our advisory council about this issue. Very important to be aware of that point. Seek to become more culturally responsive, and I like this idea. Take the risk to discover your own biases and stereotypes. I always say to Sean, I'm trying to disengage from my linear sort of Western approach, and it's a challenge, and it's some things you're not even conscious of that you're doing. So being aware and being mindful of that. Some other cultural considerations, just to become more culturally responsive. Primary source of cultural information should be your patient. Your patient knows their own culture, or at least a component of that, and can if they choose to, share that and articulate that with you. Multicultural skills must be personalized. Learn from your mistakes. Learn to reframe problems. Recognize your own biases and cultural perceptions or misconceptions, and to view psychological problems as social constructs. So really, we've covered a lot in a short amount of time. So I don't mean to brush through these as quickly. Maybe we just need to expand this to a 2-hour webinar, Kate. We need to consider that, or I need to just cut down on some of these slides, maybe. Anyway, I really appreciate everyone's attending today's webinar. It looks like we had almost 50 participants. That really means a lot to me. And again, in summary, we looked at counselor development, microcounseling skills, counseling theory, self-disclosure and keeping clear boundaries, and then briefly some cultural and ethnic considerations as well. So we've got a few minutes. Kate, I did it. I left us a few minutes for any questions. I'm sorry I haven't been able to answer questions as we go, but we've got a few
Thanks so
minutes.
much,
So
Steve.
again, thanks
While
everyone
people
for
are
attending
submitting
today
their
and
questions,
listening.
I just wanted
Really
to
appreciate everyone's
remind everyone that
presence.
we did record this session, so if you wanted to view it later, that's always an option. We'll actually email you a link to the recording in the next couple of days, along with the handouts. And feel free to share that with colleagues as well. And we offer a session in this series once a month, as well as we also have a mental health series. We've got one of those next week. That's going to be another part of our Healing the Returning Warrior series for working with veterans. And then we are going to have a behavioral health webinar coming up in a couple weeks, looking at issues of suicide. And then we're also going to have a prevention webinar at the end of the month, which is going to be dealing with historical trauma. So watch for those announcements. Hopefully you get my announcements by email. And yeah, let us know if you have any questions.
So thanks, Kate. So I see a few questions coming in, and I know I'm slotted to do monthly webinars related to counselor skills, counselor development. We have a series of 12 that are related to our essential substance abuse skills webinars. So I hope that maybe answers. I think, yeah, Drexler had asked what all do you talk about other than counseling skills. So we've got quite an extensive list of different topics that we would work through. They're all related to some aspect of working in the behavioral health and substance use disorder field. Things like components of assessment and treatment planning. There's professional readiness, ethics, several other topics, but they're all sort of centrally related to this idea of
yes, and just so people know too, this particular session is one that we offer every year because it is something that we try to do to help people. It's one of the things that can help you prepare for substance abuse counseling licensure. So we do repeat all 12 sessions of this every year. So there is one. Jennifer just asked a question. What do you mean by socio-political and socioeconomic? Maybe what are the differences between those?
Yeah, I mean, there's the idea of think of socio political as political issues that are directly connected to one's social environment or community, or that impact their engagement with those around them. So it could be politically driven policies or agendas that impact for better or worse their community, their city, their county. And then I think socioeconomic is just, again, how certain policies, economic policies, tax base, things like that impact your social world or the
And
environment,
Ashley asked a question about the
social
CEU
system
certificate,
that you
and you
live in.
can request a
I hope that makes
certificate
sense,
with
Jerry.
the file that's in that files pod. You can download it there. We also email that to you. But often, all you will need for your renewal of licensure is confirmation, or you have to write down things you attended, and so the email that we send you confirms your attendance. So most of the time that's good enough. But if you do want a certificate, you can request that with that form.
Well, again, I really enjoyed having you all in the audience. Terry asks, will you be hosting this again? And I think Kate kind of addressed that. It's cyclical, so this particular one will come back around in a few months. But we've recorded it, so you can watch it at your convenience. Again, if you can stand listening to me
I'll
talk for 90 minutes,
I'll try not
that
to. I'll try to
that
cut
might
out the
put you right
part where
over
I'm
the
yelling
edge.
to
I
my
don't
daughter in the
know,
beginning. So
Terry. So be careful if you watch this again.
awesome. Well, I think that does it for us. And yeah, thank you all so much for
Yes,
being here.
yeah.
And thank you so much, Steve, for teaching us today.
My pleasure. Always my pleasure, and happy to take any emails or any follow up. Always happy to respond in that way too. So feel free to email me. I don't know if my email is
Here it
available
is. It's actually in the little
available to
contact
them
at the
through this
bottom.
webinar.
So I just copied it into the
If not, let me just
chat
put it up there
there.
real quick. Oh, there we go. Yeah, look. Oh, thank you so much. Well, yeah, anybody wants to email me, Jennifer, we can talk more about the socioeconomic or sociopolitical components if you want to. If you want to email me, we can exchange correspondence that way. So, thanks again, everyone. We'll see you next month. Not sure, I can't remember what our topic is, but look forward to seeing some. I saw a few familiar names on the participants today, and it's good to see all of you. Hope to see you again next month.
Yep. Thank you all.
Later this month, and with some of our other webinars.